in another 8 minutes is going to be a real capsule. So orbital infections we know it can be either bacterial, fungal, can be tuberculosis, like chronic infections, or parasitic. Coming to the stages of periorbital infections as per Chandler's. So group 1 is preceptor cellulitis, group 2 is orbital cellulitis, then it goes for subperiosteal abscess, then orbital abscess, finally cavernous sinus thrombosis. So a patient can present at any of these stages to us. Causes we know it can be trauma, surgery related, or spread from a local infection like sinusitis, dental cystitis, or through a hematogenous route. This is very because we have to take a thorough history when you see a case of any infection. Coming to preseptal cellulitis, here the infection is confined anterior to the orbital septum. Most of the time it can be managed on an outpatient basis. My preferred choice is amoxicillin clavulanic acid if the patient is not allergic to penicillin, and they will respond well. Coming to orbital cellulitis, here the infection has gone behind the septum, and when you see lipedema, it is always crucial to differentiate between preseptal and orbital. In orbital cellulitis, most of the time patient will have proptosis, movement restriction, sometimes mild congestion, chemosis, and always look for any optic nerve dysfunction, that is related to apparent pupillary defect. If you don't treat properly, you can get complications not only in the eye, you can get intracranial complications also. You have secondary glaucoma, exposure keratopathy, arterial occlusion because of the raised IOP, then optic neuropathy and panophthalmitis. Intracranial, you can get meningitis, brain abscess, cavernous sinus thrombosis. So this is a case of dacryocystitis present at orbital cellulitis secondary to dacryocystitis. Treat with IV antibiotics. When you are in doubt, get a scan done. You can see the rim enhancing vision near the lacrimal side area. Coming to subperiosteal abscess. So most of the time the kids just present with lid edema. So you should be always able to rule out why this lid edema. Don't write it off like allergic edema. Always ask for all the histories, fever, the local rise of temperature, everything. Usually seen adjacent to the ethmoidal orbit, adjacent to the ethmoid sinus. You can see homogeneous or heterogeneous collection with enhancing borders. It can displace muscle and extracorneal fat. Suspect orbital abscess when you see an eccentric proptosis. Most of the time imaging is diagnostic. So you can see enhancing lesion in the supratemporal orbit. And the child presented with RFPD and she underwent drainage. So when you see a case of cellulitis, it is always important to differentiate between infective and non-infective, that is inflammations. So orbital pseudotumor, acute thyroid eye disease, then dacryoadenitis, all these are differentials, and it can be a masquerade also. So in this case, it's actually, that is the relevance of history. Patient is a known case of CA maxilla, presenting with the lid edema, chemosis, proptosis, movement restriction. It was a case of metastatic orbital lesion. So coming to evaluation, as I have already told, aim is to find inciting event, history, then assess the degree of proptosis, vision, fundus, pupil. Intraocular pressure is very, very important. Most of the time the intraocular pressure will be very high. That also has to be tackled when you manage. And the most important thing is look at the fellow eye for the ocular motility restriction. Sometimes very bad cellulitis will progress to cavernous sinus thrombosis in a matter of hours. So it needs very, very close monitoring. Coming to evaluation, get routine blood test, blood cultures, usually poor yield, especially in older children and adults. Young children, in 8% you can get positive cultures, culture of nasal swabs or local discharge or derived abscess. A few words about microbiology. Children usually staph or streptococcus, more than 9 years, and adults polymicrobial. MRSA is also emerging now. Imaging is important to detect the source, extent of orbital disease, and to classify the infectious process. So immediately when you see a patient, don't send the patient for scan. Always admit, start the IV antibiotics, monitor everything and start the IV antibiotics. Then only you send the patient for imaging. A couple of instances which I have seen, immediately saw case of cellulitis, patient was sent for imaging, patient coming by with an OPL. So that can cause lots of problems. So CT scan worsen a clinical picture, decreased color vision, any signs of CNS complications, Then proptosis and ophthalmoplegia are not responding to the routine management. MRI, most of the time CT scan is done. MRI is done if a suspect retained foreign body, especially wooden or intracranial involvement or suspected fungal infections. Treatment, always admit the patient. Antibiotic regimens, amoxicillin clavulanic acid or third generation cephalosporin intravenous. If allergic to penicillin, vancomycin with fluoroquinolone. You can add metronidazole if you're suspecting anaerobes. Suspect anaerobes if you see a macerated wound or crush injuries or presence of any contaminated foreign bodies, dental source of infection, or when gas forming organisms are suspected. So start with empiric antibiotics and change the antibiotics based on the culture report. It's very, very important. Monitor every 4 hourly. I would rather say if bad cellulitis has to be monitored every 2 hourly. Look at the first sign of response to antibiotics. Basically, the clinical signs will improve. That is, the fever will subside, child becomes symptomatically better, the pain will reduce, etc. Continue the treatment for 2 to 3 weeks. 5 days you can give intravenous followed by oral antibiotics. Then adding steroids is a little controversial thing. I usually add steroids to reduce inflammation once the child or the adult has become febrile. But there are a lot of people who add steroids right from the first day itself. Coming to the role of surgical management, abscess is suspected when you use a progression of clinical signs. But there are some specific criteria, that is high-risk criteria for surgical drainages of periostal abscess. Age 9 years or older, then frontal sinusitis. Non-medial large subperiosteal abscess, that means medial abscess you can observe. Gas within the abscess or CT or other suspicion of anaerobic infection. Recurrence after prior surgical intervention. Radiologic evidence of chronic sinusitis. In that case, you require a consultation from ENT surgeon also. Then acute optic nerve or retinal compromise. Dental etiology of infection. So this is the criteria for surgical drainage in subperiosteal abscess. So this is an abscess which had drained. It was not responding to routine line of management and the globe is displaced. Coming to chronic infections. So one is orbital tuberculosis, even though rare, but we should not miss this. That's the problem. So it can be either hematogenous or can be a direct extension from the sinonasal tuberculosis. Hematogenous usually presents as periostitis, cold abscess or fistula, or sometimes it presents as tuberculosis. Here, the patient presents with a chronic lymphedema with the pain, not responding to any other line of treatment, get a Mantoux test and take few more. And suspect tuberculosis if the Mantoux test is positive and based on the imaging findings also. As per fungal infections, we are all experienced in managing mucor. Aspergillosis, you can get in compromised and immunocompetent and immunocompromised. Voriconazole, amphotericin is alternating. Fungal, I'm not touching. Mucormycosis, actually, we are all experienced in managing the COVID time. So, chronic infections we should be able to recognize. That's the most important thing. Chronic orbital pain, look for proptosis and lymphedema, suspect chronic infections. Parasites, a few seconds. Mainly we see cysticercus and dirophilaria. Cysticercosis, CT scan, we can get an IgM also, positivity. Then dirophilaria is very common in this part of the country. Antihelminthic treatment not effective. Excisional biopsies diagnostic as well as therapeutic. So to conclude, lots of myriad of organisms responsible for infections. History is very, very important. Proper radiological assessment and treat according to the cause. Thank you.
Thank you very much, ma'am. Specific and non-specific. Specific, obviously we have etiologies. Non-specific are those space-occupying orbital lesion which is non-neoplastic, which is ruled out, which is non-infectious, which you have already seen, and it is basically a diagnosis of exclusion. It's easy to understand and learn inflammation when you have, different case scenarios. So this is a 45-year-old lady, swelling of the left eye since 1 month, painless gradual progression. So it's a gradual, painless, swelling of the left eye. You can see some amount of fullness over here. In fact, when she came in, she didn't realize that she has a puffiness in the right eye also. In fact, she has a puffiness in the right eye. Now this is what? So the next step would be definitely imaging, right? Yeah. So the CT scan, you see actually bilateral lacrimal gland involvement. And this is how clinically you see the left eye, which is more than the right eye. So what would you do next? Well, so when there is bilateral, when it is, in the middle age or an older patient, well, you definitely want to rule out any specific etiology. So you go and do a biopsy. So I'm just going to show you this video so that you exactly know how we as oculoplastic surgeons and oncologists do this surgery. So it's a very minimally invasive approach, a small incision in the lid crease to be cosmetic, and this is how the incision is made. And mainly you need to actually expose the lacrimal gland. All right, so with very subtle blunt dissection with cotton bud tips and scissors, the septum is opened, and this is where you find the lacrimal gland. Okay, so one thing that I really want to highlight here